So I have no conflict of interest. The aim, I'm going to discuss first of all the clinical approach to a child referred with preschool wheeze, which doesn't seem to be responding to treatment. I'm going to go through possible treatment options and how we're starting for the first time to do personalized therapy in a practical way. And I'm going to show you some of the potential novel approaches to prevention, success, and failure. But also, one of the things that we have to do as pediatric pulmonologists is educate our adult colleagues that, in fact, a lot of adult diseases like COPD are actually childhood diseases. It all goes wrong in childhood. So, the first things first, the clinical approach. Children with cough and wheeze fall into one of 5 categories. The normal child, which is the hardest diagnosis of all. The child who has a serious illness, perhaps tuberculosis, cystic fibrosis. This will be unusual, but essential to get right. And here is a child who was seen in one of my asthma clinics for the first time, who in fact turned out to have cystic fibrosis. They may have one of the asthma syndromes, and I'll come on to what I mean by that. They may have minor problems which may mimic or exacerbate wheezing symptoms, and they may be over-anxious, often first-time parents. So here is my first slide. This is a child with atopy, a preschooler who's referred to me, and the question of which side of the X-ray, this is clearly an asymmetric X-ray, which side is normal, but in fact actually both are abnormal. This child had a bronchogenic cyst, which you can see on this MRI scan, which is compressing the airway. And if you look down, and this is another case, if you look down with a bronchoscope, you can see this smooth indentation on the airway. This is another child, a 15-month-old girl, 4 months of cough and respiratory noises. On one occasion, she was admitted very sick, cyanose, but never ventilated, did not respond to therapy, and underwent further investigations. Here you can see the chest X-ray, and at the time it was interpreted as showing some loss of the left hemidiaphragm and that there was some left lower lobe consolidation. The CT scan, however, showed that this mass in the mediastinum, the same density of bone crossing the mediastinum. And we went on to do a bronchoscopy. And this is a fiber optic bronchoscopy. The child is free breathing. You can see I'm now going through the vocal cords. The arrow is posterior, and you can see the child is breathing quietly, but the airway ahead looks very narrowed and abnormal. You can see it's slit-like, not at all like the normal tracheal shape. In a minute, you'll see some more findings. So here, as we go down, you can see how narrow the airways are becoming. You can see some pus. You can see this white mass here, a very odd-looking mass indeed within the airway. And what this is a foreign body. And actually, if you look carefully at the X-ray, it's a toy soldier. Do you see up in the upper mediastinum? That's the soldier's head, an arm and a leg. This child swallowed the soldier. It stuck in the esophagus and eroded across the mediastinum into the trachea. And this was pulled out by the surgeons. So foreign body, a very important diagnosis. The very sudden onset of symptoms. You always must ask specifically, could the child have choked or aspirated? Sudden onset, the mother who says, my child was fine until 3 days ago and has been coughing and wheezing since. There may be abnormal physical signs, but the signs may be absent altogether. The chest X-ray may be normal, and if there's any doubt, you do a bronchoscopy. And the world record, I think my colleague, Professor Geddes, looked after a young man of 32 who he pulled out the top of a baro from the airway, and he said, "Yep, I swallowed that 25 years ago." Because he said he swallowed it, everybody thought it had been gone out in the feces, but he in fact choked it into his. This is another differential diagnosis. A 27-week preterm baby was taken down to the neonatal intensive care unit, and you can see on this first chest X-ray there's a lot of ground glass shadowing. With retrospect, it looks different on the left side. The child was left with persistent respiratory distress. And on this CT scan, you can see that this child has a grossly overinflated right lung, very small compressed left lung, and this child has a pulmonary artery sling. You can see in this angiogram, here's the main pulmonary trunk, there's the right pulmonary artery, there's the left pulmonary artery coming off the right-sided trunk and compressing the airway. Perhaps of more relevance to your country is tuberculosis. You can see here in this X-ray, in this CT reconstruction, that the main airway is compressed by tuberculous lymph nodes, and these are some of the bronchoscopic appearances that you may see of children with tuberculosis. All that wheezes is not asthma, and it's essential to take a good history and carry out a detailed physical examination. And in my country, we have overdiagnosed asthma with isolated chronic dry cough on its own with no wheeze, no breathlessness, is very unlikely to be due to asthma. And we have overdiagnosed and overtreated cough variant asthma in the UK. It does exist, but it's very rare. Many of these infants and children will require no further investigation, just the history and the physical examination. You may need some extra tests, and these should be targeted in those. You should target the tests very carefully. What about normal children? Well, we all know as pediatricians that children cough. All children cough. They may get a prolonged post-bronchiolitic cough. Viral colds. In my country, 10% of children will have more than 10 colds a year. They may last 2 to 3 weeks each time, and they have almost continuous symptoms. Otitis media is very common. In my country, pertussis has made a comeback because people are reluctant to immunize their children. Commonly, what I see is what I call nursery school syndrome. It's usually a first child. The child has been early placed in a childcare facility and gets repeated viral infections, one viral cold merging into another. And of course, it does not respond to antibiotics or bronchodilators or inhaled steroids or anything, because these are just normal viral colds. My prescription is a lemon and honey drink for the baby, for the infant, and a glass of wine for the mother, both prescriptions to be repeated. And I would most strongly recommend this reference to you. It's a meta-analysis of the duration of normal childhood symptoms. I would strongly recommend that you read this. In the history, is it really wheeze? In my country, the word wheeze is used very imprecisely for a lot of different noises, and we increasingly use a video questionnaire to determine what the parents mean by wheeze. Do they have prominent upper airway symptoms? Symptoms from the very first day of life. If an experienced mother tells you her baby was ill from the day of birth, that baby needs investigating. Sudden onset of symptoms, like I said, with a foreign body. Chronic moist cough, continuous moist cough for 6 or 8, 10 weeks, that needs investigating. Child who's worse after meals, is an irritable feeder who arches back off the breast or bottle and vomits. Is there any history of systemic illness or immunodeficiency? Continuous unremitting symptoms. I think this is a very useful diagram. Most children will have little bouts of transient cough and get better in between times. That's normal. The occasional prolonged post-bronchiolitic syndrome gradually getting better, but this child who's getting worse and worse and worse, that one needs investigation. Physical examination, we look for clubbing, weight loss, failure to thrive. About 2 or 3 times a year, I see a child with digital clubbing that's clearly been there for a long time, but nobody's looked for it. Look for upper airway disease, any evidence of adenotonsillar hypertrophy or nasal polyps, as in this slide here. Unusually severe chest deformity. Nasal polyps, I should say, in my country are usually due to cystic fibrosis. Listen for abnormal physical signs. Do a really good, thorough investigation, examination. Look also for heart, cardiac, or systemic disease. So, the next question in my country, can we diagnose asthma? What does it mean for treatment? So, what is this thing called asthma? Is it airway inflammation? Is it variable airflow obstruction? Is it bronchial hyperresponsiveness? A doctor said so. I once got an inhaler. Well, all these definitions have been used in the literature. And I would put to you that we should use the term asthma as an umbrella term for a clinical syndrome with wheeze, breathlessness, chest tightness, and sometimes abnormal cough. Just as anemia is an umbrella term for multiple causes of a low hemoglobin, and arthritis an umbrella term for hot, red, painful joints. So if you went to a rheumatologist who said, you've got arthritis, the next question you would ask, what sort of arthritis is it? Same with the term asthma. What sort of asthma is it? So if you look at an airway, we should be trying to think, what is going on in that airway? Is there fixed or variable airflow obstruction? Bronchoconstriction is an obvious one, but mucus plugging, the loss of these guy ropes because the mother smoked, giving airway instability. But if they have got bronchodilator hyperresponsiveness, they get a beta agonist. Is there airway inflammation? Is it beneficial? Do they have the key thing? Do they have airway eosinophilia? In which case, inhaled steroids are firmly indicated. But if they don't, they are not indicated. Do they have airway infection and impaired host defense? In which case, antibiotics. And this is the late, great Freddie Hargreave, who was the first person who really started looking at airways in this logical, concise manner. These are his ideas. So what about treatment? Why would I want to treat? I might like to say, well, okay, this child is wheezing with viral colds at the age of 3. I want to stop that child going on to develop school-age atopic allergic asthma. And how can I do that? Or I might want to treat symptoms. And I'll come through some of these options. So one of the mistakes we made was to think, well, inhaled steroids are great treatments for school-age asthma. Why don't we start them early? Because that will prevent the child developing asthma. Well, 2 studies, the PEAK study and the IFWIN study, both tried this approach, and continuous inhaled steroids made no difference. Starting them early did not affect the prevalence of asthma. You can see in the PEAK study here, 2 years of inhaled fluticasone, mild symptomatic benefit, but after that was stopped, the disease came back and there was no disease modification. This is the Danish Coughs study, same intermittent inhaled steroids, and they didn't work to prevent going on to severe persistent wheeze. And interestingly, from the Manchester study, this shows on the vertical axis airway resistance, those who were treated with fluticasone, a single course of fluticasone, in the long term had more airflow obstruction than the group treated by placebo in a randomized study. Now, what this does not mean is throw away all the inhaled steroids. What it does mean is please do not use inhaled steroids unless you've got something to treat, like eosinophilic inflammation. So, what do we know about inhaled steroids? In this study by Nicola Wilson and Mike Silverman, many years ahead of its time, continuous inhaled budesonide not affect the prevalence of preschool wheeze, viral preschool wheeze. This American study, they used nebulized budesonide, because that's the only steroid by aerosol they're allowed to use in preschoolers. I never use it. They showed if you treated them at the time of viral wheeze with either nebulized steroids or Montelukast, they did better than standard treatment. Another American study, this enormous dose of fluticasone given intermittently reduced prednisolone requirement, but what it also did was cause growth suppression. And in this study, they compared intermittent and continuous nebulized budesonide to prevent wheeze, and there was no difference. Unfortunately, no control group, so we don't know whether they were equally effective or equally ineffective. And these are data from our group looking at BAL eosinophils, those with viral wheeze, those with persistent wheeze, those with controls. And you can see a proportion of both groups have airway eosinophilia, but symptom pattern really did not help you. You can see they look very, very similar. And if you look at Atopic, you can see, yes, as a group, the atopic wheezers have more eosinophils, but there are some atopic wheezers with normal airway eosinophilia. Now, this is a really important study, the infant study from North America. 300 children aged 12 to 59 months. They compared in a three-way crossover study daily inhaled steroids versus daily leukotriene receptor antagonists versus as required inhaled steroids. And they used a complex composite outcome, and they pre-specified aeroallergen sensitization, gender, and wheeze attacks as pre-specified predictors of response, but not blood eosinophil count. So here you can see, first of all, a lot of these children got better. 60 out of the 300 got better. And you can see in terms of the probability of an asthma attack, the red line who did best was daily inhaled steroids. The yellow line that did worse was leukotriene receptor antagonists. And if you look here, those who were aeroallergen sensitized, they were the group that did much better on regular inhaled steroids. The next thing they did is do a post hoc blood eosinophil analysis, and they arbitrarily cut off of 300 cells per microliter. And again, it is that group with blood eosinophilia, they're the group that respond to inhaled steroids. And if you combine aeroallergens and blood eosinophil count, you can see the best responders of those who have a blood eosinophil count of more than 300 and are aeroallergen sensitized. And this is the first step towards personalized medicine in preschool wheeze. So, simple tests that we can do. We can look for aeroallergen sensitization. We can do a full blood count. We did some studies looking to see how well the blood count predicted airway eosinophilia. In this study, 64 children with various diagnoses underwent induced sputum. 61 of 64 we were able to get a sputum sample, and in 21 who were having a bronchoscopy as well, we compared induced sputum with bronchoalveolar lavage. And this is the sort of thing you see with an induced sputum. You can get very nice cellular morphology. You can see a squamous cell there, macrophage there, peripheral neutrophils there. And they looked at, in fact, induced sputum was not a very good guide to whether there were eosinophils in the BAL, but blood and BAL eosinophils correlated well. So here you can see in this panel here, both the BAL and the blood eosinophil count was elevated. Here, both they were normal, again suggesting that the BAL eosinophils are predicted by the blood count. And note that some wheezers, however, some had a raised eosinophil count, but not all did. And what we want to do is target inhaled steroids for those children who had an elevated blood and airway eosinophil. So as I said, induced sputum is good for infection, but a poor marker of airway eosinophilia. Sorry, if there's no blood eosinophilia, there's likely none in BAL. But of course, we've got to be aware that there may be other causes of a raised blood eosinophil count independent of the airway, atopic dermatitis, and of course, parasite in areas where parasite infections are prevalent. Again, the prevalence, the use of this test may be less valuable. I would strongly urge the young investigators listening to this, go out and do the studies in Sri Lanka. Don't assume that the disease that I am seeing in London is the same as the disease you are seeing in Sri Lanka. So, what about leukotriene receptor antagonists? What is their role? So, cisternal leukotrienes are raised acutely in viral wheeze. Parents probably won't medicate well children. So this was the preempt study, over 200 children, and they showed that if you gave intermittent Montelukast just at the time of viral wheeze, this was superior to placebo. And you've seen this study before in this talk, that intermittent Montelukast was better than the standard treatment. However, unfortunately, in this huge study with over 500 patients in each group, there was no difference between placebo, intermittent Montelukast, and daily Montelukast. Then this Jonathan Griggs weight study, nearly 700 patients randomized to intermittent Montelukast, nearly 700 randomized to placebo. 1 year follow-up, there was no benefit of leukotriene antagonists. So at best, from these last two studies, the AAI and the Lancet Respiratory Medicine, most preschool wheezers are not going to respond to Montelukast. And you may well recognize this famous picture of the scream. The prevalence of psychiatric side effects of Montelukast is really quite high. It can be as high as 20%. A lot of children to whom I prescribed them have discontinued this because of night terrors, other behavioral side effects. So how do we, what do I do now? Well, if they've got episodic symptoms, I just treat them episodically. First choice is bronchodilators, salbutamol or ipratropium, if they need treatment at all. If they're just making a noise, do they need treatment? Of course, it is not a trivial exercise to give an inhaler to a cross toddler. I do trial them on intermittent leukotriene receptor antagonists, but usually it doesn't work. I next go to intermittent inhaled steroids at a dose of no more than 200 micrograms of beclomethasone twice daily, starting at the first sign of a viral cold. The counts of despair is combinations of the above. Many of these children are non-responsive. What about if they've got multiple trigger wheeze? If they've got symptoms, if they've got symptoms, not just with viral colds, but also in between colds. So step one would be for me to commence treatment with beclomethasone via a mask and spacer. I then see the child 6 weeks later and find out, is the child symptomatically improved? If they're not improved, I consider alternative diagnosis or therapies, but I would discontinue the steroids because they're not working. If they're completely better, I would still discontinue the steroids and see if the child relapses, because many children will just have transient symptoms, and I do not want to keep them on inhaled steroids if they don't need it. And if the symptoms recur on stopping treatment, well, then I restart inhaled steroids to the lowest dose needed to control symptoms. But if you do this 3-stage protocol, you'll avoid giving patients inhaled steroids long term when they do not need it. Is there any role for macrolide antibiotics? We know that these antibiotics have multiple anti-inflammatory, antiviral, and other effects, as well as being antibacterial. In this very difficult to interpret study, 158 asthma-like episodes, whatever that means, in 72 children in the Danish Coughs study, and they showed that symptoms were shortened. In this study, when they looked at more severely ill children who'd been previously had to be prescribed at least one course of prednisolone, they found azithromycin reduced the prednisolone requirement. But in this latest study, 300 children in the emergency department, azithromycin azithromycin had no effect on any outcome that was worthwhile. And of course, azithromycin, the worry about widespread use of macrolides is that you will get bacterial resistance. So I reserve azithromycin treatment only for those children who are having acute, really severe wheeze, heading for HDU or the PICU. I think it should be reserved only for those with severe symptoms. What about prednisolone? What about prednisolone in acute preschool wheeze? Well, this is a meta-analysis of 1,700 children aged less than 6 years in 11 studies in various different settings: outpatients, inpatients, and the emergency department. And overall, prednisolone had no benefit on admission rate for these children. In outpatient studies, if anything, those who got placebo were less likely to be admitted. If you're in the emergency department, perhaps there's a small benefit of oral corticosteroids. So here you can see in panel A, hospital admissions, no effect of oral steroids. Outpatient studies, you can see actually placebo did better. Emergency department studies and hospital admissions, you can see, yes, there was a small prednisolone effect. Further results for all comers: if you give a course of steroids, you're still quite likely to have to give more. If you're an inpatient, perhaps the very severest ones, there may be a benefit. And here you can see the risk ratio. So all comers, knowing doesn't reduce the steroid dosage. Yes, if you're an inpatient, it may well reduce your requirement for further steroids. So what this is saying is that most children with preschool wheeze don't benefit from prednisolone. Oral steroids for preschool wheezers, I'm not talking school age asthma, oral steroids for preschool wheeze is a hospital-only medication. And there is a hint that there may be some benefit in sicker patients. Mechanism not known. Could this be a non-genomic effect reducing airway edema? Now, as I've said, this is not a community medication, not even for every child admitted to hospital, possibly multi-trigger wheeze with a severe attack, and possibly severe episodic viral wheeze. And this is Jonathan Griggs' study. Again, you can see in which they randomized nearly 700 children to either prednisolone or placebo. In this study, sorry, the bottom panel is Jonathan Griggs' study, 687 patients, no effect of steroids. This top study recently, by coincidence, 170 minutes reduction in hospital admission time, and that was significant. But really and truly, the effects are absolutely trivial if they are there. So yes, for really severe wheeze, not as a routine medication. So how do we define future risk, and future risk of what? So this is looking at risk factors for going on in a birth cohort study from going on from episodic wheeze as a toddler to school age asthma. And the three things that come out: if you have acute attacks of wheeze, if you have multiple aeroallergen sensitization and you're exposed to tobacco before age 3, and if you're exposed in all the area under the curve, the ROC curve is more than 90%. So these are the children who are going to do badly and progress. Unfortunately, what we do not have is a medication yet that will prevent them progressing. So just reminding you of how lung function progresses. This is Global Lung Initiative data, nearly 100,000 records. They constructed predictive equations for spirometry. And here you can see for males, you can see your lung function increases to about the age of 20 to 25, and then it gradually reduces. So what can happen, you can be born, if you're born with impaired lung function because your mother's smoked, or you fail to develop your lung function normally in childhood, or if you have an accelerated rate of decline of lung function, this puts you at risk of long-term respiratory disease. And let's look at COPD. The adults make a great play about COPD being an adult disease. It isn't. It all goes wrong in childhood. So route 1 to COPD, if you get to your correct baseline, if you develop normally in childhood, your risk of COPD is 7% only. On the other hand, if you do not get to your normal plateau, if childhood or prenatal or antenatal factors prevent you developing normally, you have a 26% chance of COPD, and the rate of decline is normal. And the rate of decline, it was always said, oh, it's because they smoke, their lung function declines faster. Not in this study. There was no consistent effect of smoking in this or 5 other big adult cohort studies of COPD. It all begins in childhood. And this is a fascinating study. This is the Melbourne birth cohort. They studied them with severe asthma, recruited at the age of 7 to 10, retained 76% of them to age 50. And at age 50, they rephenotyped these patients into non-asthmatics, current asthma, remitted asthma, and COPD. And they tracked the lung function back to age 70 years. And you can see that those who had COPD at age 50 already have the worst lung function at age 10. Current asthma is intermediate between normal and remitted asthma. But you can see even at age 10 there is this separation. So the reasons for this separation will have been when they were much, much younger. And if you had severe asthma as a child, your odds ratio for COPD was even stronger than with smoking. And this is a European study, 13,000 patients, and they looked at childhood risk factors, maternal asthma, paternal asthma, childhood asthma, maternal smoking, and severe childhood respiratory infections. And the more of these risk factors you had, the worse you did. FEV1 on the vertical axis, age on the horizontal axis. And if you had early childhood disadvantage, whether you smoked or not, you had lower lung function, you did not catch up, you had a faster rate of decline and more COPD. So if we're going to make an impact on adult COPD, we have got to do it very early on in childhood. And it's not just respiratory disease. This is the Tucson study, 1,400 participants, and they looked at terciles of FEV1 and mortality. 122 died in the 3rd decade of all causes, and if you had a low FEV1, you were at risk of early death from all causes. And there are other studies which show the same thing. And every 10% decrease in baseline FEV1 predicted associated with an increased all-cause mortality risk of 15%. So that an abnormal lung function is a marker for risk of all sorts of other diseases, cardiovascular and metabolic. This is a Welsh miner, and it's a canary. He's in his cage, and he carries a canary in his cage not because he liked music or birds, but because when he went down the mine, if the canary stopped singing, that was because it was dead because it had inhaled carbon monoxide, and that meant the miner had to escape quickly. So why is clinically trivial lung function loss associated with greater adult mortality? There's plenty of studies that show this. Why should this be? Well, very interestingly, you know, for example, that birth weight is a determinant of lung function. Birth weight variability is driven to some extent by fetal genotype, and genetic factors are the major risk factors between cardiovascular risk and birth weight. So the genes that are driving birth weight and spirometry are also driving type 2 diabetes, hypertriglyceridemia, coronary disease, blood pressure, etc. So if you've got respiratory disease, this is a bad prognostic sign. And interesting, this is maternal smoking and DNA methylation, epigenetics, and they looked in this meta-analysis at DNA methylation in peripheral blood at 8 sites, and they found 3 loci of methylation significantly related to prenatal exposure with the mum smoking and the adult smoking. And you can see that all 8 loci were significantly related to adult smoking, and there were significant links of epigenetic modifications to DNA to risk factors such as blood pressure, triglycerides, and habitus. So prenatal smoking and also postnatal smoking, very bad news, and epigenetic modifications. So smoking, if you like, has a sort of triple whammy. Crossing the placenta affects not just the lungs, but the heart, the liver, and other things, causes epigenetic modification, causes low birth weight, all these things, and we've really got to hit hard at smoking in pregnancy. So can we prevent at least some future risk? Something can be done. And this is a European study. The Amish and the Hutterites were families that fled from Europe to America to avoid religious persecution. And you can see genetically, they are extraordinarily homogeneous population. They are genetically very, very similar. And the Amish have much lower prevalences of asthma and atopy, much higher environmental lipopolysaccharides, and that's the Amish are using very traditional farming methods, whereas the Hutterites have gone over to tractors and modern methods. Lots of different microbiological exposures. So the Amish, with their low prevalence of asthma and atopy, have a lot of lipopolysaccharide in the environment. The Hutterites had more peripheral blood eosinophils, but the Amish were more neutrophilic. Amish monocytes were suppressive, and the median levels of innate but not adaptive cytokines were higher in Amish children. And in these mouse studies, Hutterite dust treated mice had more airway eosinophilia, but if you gave them Amish dust to inhale, this inhibited type 2 inflammation. And this needed innate immunity. And you can see in this volcano plot, there's a profound changes in how genes are regulated, both upregulated and downregulated, in these genetic, almost identical populations. Something else can be done. This is a study in Denmark comparing supplementing pregnant women with either fish oil or olive oil as a placebo, double blind. And they followed the offspring up for 3 years, and nearly 700 completed the trial. Primary endpoint was persistent wheeze or asthma, and the risk of persistent wheeze was reduced by fish oil, giving the mothers fish oil in pregnancy. So there is something we can do. It's proof of principle. And the mothers who benefited most were those who had the lowest levels to start with. What about vitamin D in pregnancy? And this is a much more disappointing story. The 6-year follow-up of the VDART study, in which they supplemented pregnant women. Age 3, there was a small beneficial effect possible, and it became significant when they did a meta-analysis with the Danish study. There was speculation, could this be affecting antiviral immunity? But at age 6, everything had disappeared. So you can see at age 6, there's this small, very early effect, but the VDART study, no effect at age 6. And you can see again in the Copenhagen study, perhaps the trend early on, the two combined early on were significant, but everything has gone by age 6. So unfortunately, vitamin D supplementation in pregnancy is not the answer. What about smoke? What about tobacco legislation? This was a great paper from Flanders in Belgium, and they looked at how anti-smoking legislation gradually tightened up. No smoking in public places, none in restaurants, none in bars serving food. And they looked at preterm birth. And if you look here, as each piece of smoking legislation is introduced, the amount of preterm birth declined. So we've got to make sure we are protecting our children from tobacco smoke. And what about pollution? Another very important topic. Antenatal pollution. This is 624 children with spirometry age 4.5 years. They looked at exposure to benzene and nitrogen dioxide. And here you can see benzene exposure on the horizontal axis, FEV1 on the vertical axis, and you can see that the more benzene exposure in pregnancy, the worse the lung function, age 4.5, and the same for nitrogen dioxide. In this case, they only showed an effect in pregnancy. And it was worse if you were allergic and worse if you came from a low socioeconomic status family. And in this, again, a really important study from North America, the Southern California study, they looked at 3 cohorts of children, 1994 to 8, 1997 to 2001, 2007 to 2011. 5 communities, starting in school age. They did annual spirometry, and air quality improved over time with government policies. So here you can see this is a slightly odd graph because instead of the usual way, the lower you are on the axis, the worse the pollution. So here, very little pollution, and for all these things, nitrogen dioxide, PM2.5, PM10, in successive cohorts, as air pollution declined, so lung growth improved. We've got to protect our children from pollution. So in summary, what are my take-home messages from this presentation? Preschool wheeze fits into 5 groups. History and physical examination is initially used for that categorization. Vast majority will not need particular tests. However, we are starting to get onto the verge of personalized medicine for preschool wheeze, rather than giving steroids to everybody or to nobody. Acute attacks, atopic sensitization, tobacco exposure predict a high-risk group, for later COPD and cardiometabolic mortality. And we must try to find a way of preventing the disease developing. And speculatively, could asthma be caused? Does the Amish-Hutterite data suggest that asthma could be caused by bacteria or modulated by bacteria? So I'd like to thank you very much once more for your kind attention, for listening to me, and for this invitation. These are my 6 grandchildren, 2 of whom are twins who need to be protected from smoke and pollution. I hope the lecture was of value to you, and I'm very happy to take any questions. Thank you very much indeed.
Yeah. Thank you very much, Professor Bush, for that excellent presentation. Obviously, from a world expert and so much of up-to-the-minute information. Thank you so much. We couldn't have got all that information from anyone better. We got a whole load of questions actually for you. So we're going to tax you to quite a bit of things. Can I start off with a couple of things that came in pretty early, actually. Can I start off with the first one? The first question that came in actually very early on is the role of viral respiratory infections in preschool wheezing, because this is one of the commonest problems that we come
Absolutely.
across, especially in primary care. So, what are your thoughts on role of viral respiratory infections in preschool wheezing?
Absolutely. And as the questioner quite rightly implies, viruses are very important in triggering acute attacks of wheeze. Interestingly, there are data suggesting that if you look, you may find bacteria as well. I would encourage you to look. I mean, Heather Czar in the Drakenstein birth cohort study in African townships has shown that multiple infections are very common. And she has, and this is an illustration about how things differ across the world. In Perth, Australia, it doesn't seem as if preschool wheeze, it doesn't seem as if viral infections result in your lung function being deranged. But in the African study, acute severe lower respiratory infections are an independent risk factor for impaired lung function later on. There's a lot of questions in people's mind. Does our early RSV infection cause asthma later on? Evidence we have from the palivizumab studies is the answer is probably not. But viruses, yes, absolutely important. Influenza immunization, we don't have many viral strategies, but influenza immunization I consider to be really important in this group.
Thank you very much. I think our impressions in Sri Lanka as well, that as much as there are viral infections, that we also have, as you quite rightly mentioned, about the impact of bacterial infections as well. The second one is that what about the phenotypes of preschool wheezing? Is there a proper classification? I know this is a bit of a contentious topic at the moment. There was a lot of hype about this a few years ago, but I think now there are some, mainly because of the overlap of the phenotypes. Any thoughts on this?
Yes, so on a practical basis, I try in the history to distinguish those children who just wheeze with viral infections and those who wheeze with viruses and between viruses. And that's difficult because you and I rely totally on parental perception of symptoms. And if they're not good symptom perceivers, you'll put them in the wrong category. The second thing is that if you follow a child over time, they may change their pattern of wheeze. We all know that. So you need to keep following them up. Our data increasingly is that pattern of wheeze is a rather unreliable guide to whether they've got airway eosinophilia and are likely to be steroid responsive. What I think is important is that I don't know, I'd be interested to know the Sri Lankan experience, but in my experience in the United Kingdom, parents are very reluctant to medicate well children, and it's very difficult to get them to give regular medications. So probably those who are perceived as having intermittent symptoms will in fact be only treated intermittently, whatever I say. I don't know what your experience is in Sri Lanka.
Very much the same, actually. The our problem is really the little kids who have repeated sort of episodic symptoms rather frequently. Then only the problem starts. Actually, the intermittent ones who come in sort of, kind of once in a couple of months and things like that, they're really not that much of a problem. But then those who get fairly frequent ones, where they are sort of repeatedly ill, those are the ones that we have trouble with.
I absolutely agree with you.
Yeah. Then related to the things that we already discussed on the first question, there's another one that has come in which is a bit related to that. I've said certain young ones, especially infants, tend to have post-infectious wheezing following either bacterial or viral pneumonia. what should be the best way to manage them? What is the role of steroid inhalers or Montelukast in them? That persistent wheeze following either bacterial or viral pneumonia.
So Tony Milner did a study in children with bronchiolitis diagnosed clinically. Probably most of these were viral, and he did a double-blind placebo-controlled study looking at beclomethasone or placebo to prevent post-viral wheeze. And it was double-blind, and one group were doing much better. So he thought, we've solved the problem, give them steroids, it'll be fine. But when they cracked the code, it was the placebo group that were doing better. And he was furious. He tells the story against himself. He was furious and made them reanalyze all the inhalers because they must have got the labeling wrong, but they hadn't. So for prolonged post-viral wheeze, particularly in a non-atopic child, in my hands at any rate, inhaled steroids have very little role to play. I would give a caution about inhaled steroids. Clearly, in school-age children with atopic allergic asthma, they are fantastic treatments. But we also know that particularly the new modern potent inhaled steroids may be topically immunosuppressive, and in adults there is a greater risk of airway infection with them. So I think we need to be careful to make sure we just don't think that inhaled steroids can just be given out willy-nilly to anybody just because they're making noises.
There were two Milners in respiratory pediatrics. I think this is the younger one, I think.
This is Tony
Right?
Milner, yes.
Yeah,
Yes,
that's right. Yes.
a very good friend.
Then there is there's one saying that would you kindly explain if there has been an impact of cow's milk intake and equivalence in infancy and predisposition to airway allergy and wheezing. As I see, atopic dermatitis treatment options at an extreme case, empirical avoidance of cow's milk renders some benefits.
Yes, so very commonly in my practice, people come and say he must be allergic to something. Well, in my hands, I don't find allergy very much unless there's something really obvious. They're covered in rashes, they've got diarrhea. But for the average wheezer, particularly the intermittent wheezer, I find it very difficult to believe that if you're giving a child milk every day, you will get just intermittent symptoms. And I would also caution that I have seen children in London losing weight because their parents have put them on some fancy diet for alleged allergies. If you're going to exclude something from a diet, I think it's essential you get a pediatric dietitian or nutritionalist to make sure they're still getting all the right things in their diet. Because children, as we all know, children are very fussy eaters at the best of times. You want to be, it's not a benign thing to cut it out.
Cow's milk protein allergy as a trigger for this kind of thing with wheezing should be pretty rare, I would think. I mean,
I
I have
completely
always
agree with
thought.
you. I completely agree with you. And usually there are other signs, but for the vast majority, allergy has no role to play in, or at least food allergy, I should say, has no role to play.
I think there is a question that would come in sort of. It probably has come in from India. India is more known for air pollution than any other country in the world. However, there has been relatively less airway allergy manifested, which is peculiar. Is there any ulterior causative that exists purely in genetics? I'm not quite sure what is meant by that. But
Yeah,
I
I mean,
think there is something about the air quality and pollution in the Indian atmosphere.
so. I think the situation is a complex one. There are clearly genetic predispositions, and I suspect the important genes may vary with the environmental exposure. There are certainly direct irritant effects of pollution that are independent of allergy, and allergy effects independent of pollution. The two together, allergy and pollution, are synergistic and they have a combined. They have a bad effect. What I would say also is that I think the effects may vary from country to from country to country. There may be different. I'd be interested to hear, are there different indoor pollutants in Sri Lanka? I mean, I know in India there was a great paper from India about interstitial lung disease, which was a hypersensitivity pneumonitis driven by water coolers. So we need in our own countries to look, what are the pollutants, what can we do to protect our children?
There is another one on the role of leukotriene receptor antagonists in preschool wheezing, but I think you touched on this quite a bit as well. But then I think they are also added to that the use of leukotriene receptor antagonists as prophylaxis in preschool wheezing. Is there a real role in the use of this as a prophylaxis?
In my hands, I found them very disappointing. They're very commonly I mean, very common side effects. I warn all the parents about side effects: head banging, tantrums, bad behaviour, and very often ineffective. Just occasionally, you find somebody who responds dramatically, and I've never been able to predict in advance. That's why I would give them a trial. But if they're not working, I would discontinue them. And if the patient is exhibiting side effects, I would discontinue them.
There is another one on a question that has come in. We have come across children with wheeze in this age group who are on combination inhalers. Is there added benefit over steroid-only inhalers?
So I think that's a really important question, and something I'm afraid I'm cross about. The pharmaceutical industry has really pushed combination inhalers both in school children and preschoolers. I know of no decent study in preschool children about the safety or use of combination inhalers. And personally, I would only use them if there was a preschooler I saw who was 3 or 4 years old, who was covered in eczema, who was using multiple doses of salbutamol, then I might consider it. But for the vast majority, no.
Patients often say that respiratory symptoms got worse with a new pet, or possibly a cat who was brought into the house. How should we respond to that? Should we attempt allergy testing?
Well, I'm not a great fan of pet cats. I would personally hurl the cat out on the basis that if you with a history like that, if the allergy test is positive, then game, set, and match. But if it's negative, maybe the child has yet to manifest as insensitivity. I know pet cats are the English disease. There was one survey in England where 1 child in 3 preferred the cat to their brother or sister. 1 child in 3 believed the mother preferred the cat to their father, but only 1 child in 6 preferred the cat to the grandparents. So I was pleased with that. So I would get rid of the cat. And frankly, children are a big enough tie without pets. My wife always forbade pets in the house because she said she knew who would be looking after them. Then she said no. So I'm dead against pets. So very un-English, I'm afraid.
Uh,
Do Sri Lankan pets? Are pets common in Sri Lanka?
yes, I think there are quite a bit of this thing because as companions, I think mostly that they're quite fond of cats and dogs as well. But there is a misconception to a certain extent that they are a bit allergic generally to the fur of the cat. But actually, what is known is that it is to the saliva and the proteins of the saliva that they are allergic to, and the cats lick their fur and things very frequently, and it's the proteins of the saliva that they're allergic to, and it's not the fur itself. There is an interesting question about the predictors of childhood and adult asthma, when you take into consideration the symptoms of wheezing in the preschool age. Of course, there are all these things that from I think Rodriguez,
That's
who had
Rodriguez.
worked
That's
on
right.
these predictors of asthma as far as preschool wheezing goes. What are your thoughts on all these things? It's a bit of a difficult sort of problem to be able to predict from that very early age as to what is going to happen later on. And things like for us, especially in countries like Sri Lanka, eosinophilia of 4% is almost everyone here would
Yes.
have eosinophilia of 4%.
And that's a really important point you've made, because that really stresses that you simply cannot uncritically take a study from North America and apply it in Sri
Yeah.
Lanka or South Africa. The bright young investigators need to do these studies and see, is it relevant to Sri Lanka? You're absolutely right. I mean, in a high income setting in North America, if the negative predictive value of these indices is high, so if you're non-atopic, your parents are non-atopic, they don't smoke in pregnancy, you don't have any food allergy, you are very, very unlikely to go on to get asthma. The converse, the positive predictive value of the Castro Rodriguez and other indices are not much better than flipping a coin. So many people at so-called high risk, in fact, do not go on to develop asthma. The three, as I said, in the bad risk group are bad acute attacks of wheeze, polysensitization to aeroallergens, and exposure to tobacco smoke before the age of 3. These are all predictors, but we need better. This is not good enough, is it? We need better predictors and better markers of response to treatment.
It's another question about the now when you have to use inhaled corticosteroids in this kind of age group, it's not the easiest of things to administer these
Right.
drugs to these little fellows. And there is a question about how to select the spacer device for this age group. Any thoughts on the selection of actual spacer? I find that it's not the easiest of things to administer inhaled corticosteroids through masks and things to these little babies and maybe even children of 2 to 3 years of age. What are your any thoughts on this?
Well, the first thing to say is you're absolutely right. It's very easy for me to say, give this child 2 puffs twice a day, and very much harder to actually do it. And we also know if the child is crying, no steroid gets in at all. So it's a very difficult thing. I tend to use small volume spacers like the ABLE spacer, simply because they're less frightening to the child than bringing a huge one along. Our respiratory nurses are much better than professors at helping parents learn how to use these devices. But it is not an easy thing at all to use inhalers and spacers for preschool children. I completely agree with you.
Yeah, there is another interesting question on do we have evidence of effect of passive smoking during pregnancy and early age of childhood as a risk factor for asthma? Because our mothers usually are exposed to passive smoking than active smoking, especially in countries like Sri Lanka.
So yes, we do, and passive smoke exposure both during pregnancy and after pregnancy is very, very bad indeed. I would also add into that, I don't know yet if you have this problem in Sri Lanka of e-cigarettes and vaping and things. Giving nicotine is a very toxic substance, for the developing lung and the developing brain. So we should do all we can to discourage smoking by both parents.
What about third hand smoking? I think that has also come into play now in some of the countries. I think that also probably has some effect now, because I think even that has an effect.
So sorry, third hand. Could you explain to?
No, that is where the smoke, it's not actually exposure of direct exposure to smoke, but where the smoke hangs on to other surfaces like furniture, walls, and other sort of inanimate objects. Like, because there has been some work that has been done on these things as well, as far as other things are concerned, but they have not been looking at the exposure to third hand smoke in as far as medical conditions are concerned. Well, I
Yes,
think that will come into prominence as we go along.
I suspect you're right. And I think what I would say is I can't think of any sensible biological model whereby exposing your baby to third hand smoke is anything other than a very bad idea indeed. So I
Yes,
would just
quite so. Quite so.
simply, I don't know that anybody's done that study. The other thing, of course, is you want to prevent children taking up smoking. And if they associate early on the smell of tobacco with the sort of mother's warmth and cuddles and things like that, that's a very bad thing in my view.
Yeah. Now I'm going to sort of ask you something uh, which is a bit tricky actually. What about the conditions like bronchiolitis obliterans that can probably start in this age group of preschool age group? Because we have had quite a few patients in Sri Lanka in whom it has started in this age group, because it has been a major problem when it does start in this age group.
So absolutely. So in my country, it's usually adenovirus, occasionally mycoplasma, and obliterative bronchiolitis is very difficult in my hands to treat. They don't seem to respond to anything. We often give them azithromycin 3 days a week. Um, we hope that as they get better, they will improve to some extent. They seem to stabilize. I've got, she's now an adult. I looked after all her childhood, who had an FEV1 of 30%. She had adenovirus. She was desperately sick. She was on oscillation and nitric oxide as a baby to save her life. Still got the lung function of 30%, but she's incredibly active, climbs mountains, does all sorts of things, got a Duke of Edinburgh's Gold Award. So they said, but there are those who are chronically in oxygen even into the late teens, and I have nothing to offer them. I think again, if there's some smart young investigator listening to this, find some way of regenerating the lung, and you'll make a lot of friends.
It's quite surprising, really, the degree to which some of these children with obliterative bronchiolitis, the degree to which they are able to somehow compensate,
Yes, I
the
agree.
degree to
Yes,
which they are. I had quite a few of them when I was at Ledridge Hospital, but it's very, very surprising the degree to which they seem to cope, actually.
yeah,
Um,
I agree with you. I agree with you.
well, we got a few more, I think. I think we have taxed you enough. I think other people are also saying, well, it's about time we gave you a break. I think we dragged you from one of your clinics. Is that right?
It was a meeting that I was very glad to get out of, but I would always like to make friends. What I'm very much hoping is that when in happier times, when COVID is finished, we will be able to watch cricket and face to face and
Yeah.
be face to face in Sri Lanka.
Well, I think more importantly, I think we need to get you over to Sri Lanka. I think more
I would
important.
love to come. Trust me, I
Um,
would love to come.
right. Anyway, thank you very much, Professor Bush. It has been a pleasure and a privilege to have you with us. at least virtually, over the internet. But it's such a fantastic thing, at least to have you over the internet. And it has been such a wonderful experience to have you. I'm sure the audience enjoyed having you with us, and such a merciful uh, declaration of all the up to the minute information that you gave us. So thank you very much on behalf of the Childhood Respiratory Disease Study Circle of Sri Lanka and the Sri Lanka College of Pediatricians. Please accept our grateful thanks. Thank you so much.
Thank you so much. And may I say, I've sent the slides across. If you want to distribute the slides, please do. And if anybody has any questions, my email address is on the slides. Please email me. And thank you so much once again for honoring me with the invitation.
And have a great evening. Thank you.
Thank you so much.